a BioLA's webinar series. We're very excited to welcome Dr. Ben Curtis again as our speaker. The lecture this evening is titled Frenectomies with an All-Tissue Laser. This is part 2 of a 2-part series focused on this topic. Tonight, Dr. Curtis will be discussing indications and techniques for frenectomies from early childhood to adolescence. Now, if you happen to miss part 1, no worries at all. You can view part 1 in the BioLA's Webinars On Demand library. You can find that library at education.biolas.com. Part 1 was focused on infants, so please check that out if you did miss it. Let's Talk Dental is our new webinar series with a focus on a diverse range of topics relevant to today's dental community. Dr. Curtis's 2-part series on frenectomies are the first in a series of webinars we're hosting focusing on tethered oral ties and the treatment of tethered oral ties. Our next webinar on March 21st will offer a lecture on myofunctional therapy with Megan Van Noy, an expert in that field, so please check that out. These webinars are a lead-in to our annual conference that we'll talk a little bit more about called Tequila and Tongue Ties. The next Tequila and Tongue Ties is quickly approaching on April 19th and 20th in Miami, Florida. This is a 2-day conference offering a comprehensive approach to tongue tie treatment, including lectures on minimally invasive treatment using the WaterLase all-tissue laser, patient education, and social media workshops. And the conference will end with a multi-hour session on myofunctional therapy. For more information, I would encourage you to visit the website for that conference at tequilaandtongueties.com, and you can also go to biolase.com and click on education to find more information on that. Okay, we are hosting tonight's webinar on the Zoom platform as always, and we welcome your questions during the lecture and the Q&A feature. As you can see, we encourage you to chat with us and ask us questions. We'll wrap up the session with just taking a few minutes to address your questions with Dr. Curtis. At the conclusion of the lecture and Q&A, I'll provide everyone with BioLA's education CE process along with additional web resources you can access to continue your learning journey in laser dentistry, including upcoming courses you may want to consider, webinars like I mentioned about the myofunctional webinar on March 21st, and additional information. So with that, let me quickly introduce Dr. Curtis, and then I'll hand it over to him. Born and raised in Wills Point, Texas, Dr. Ben Curtis was inspired to become a pediatric dentist after the poor dental experiences he had as a child. He strives to make dental visits fun for kids by providing gentle, compassionate care. Dr. Curtis graduated from Texas A&M University with a Bachelor of Science in Biomedical Science and a minor in Business. He attended Baylor College of Dentistry, where he was awarded his Doctorate of Dental Surgery. Remaining at Baylor, he completed his rigorous pediatric dentistry training. And of course, Dr. Curtis and his wife, Rachel, are proud parents to Birdie, Dodson, Emery, and Goldie. And Dr. Curtis is tuning in tonight from his practice in Kenton, Texas, Curtis Kids Dentistry. So with that said, I think it's your turn, Dr. Curtis. I will hand it over to you, and thank you so much for leading our lecture tonight.
All right, my pleasure, Joe. Thank y'all for having me again. So as Joe said, this is part 2 of a series here. So we're going to wrap it up with frenectomies. We're going to focus in on childhood and adolescence. And let's go ahead and dive on in here, guys. So what we're going to be seeing, let's move this along. There we go. So first off, who am I? Joe gives you the real spill of who that is, but here's me giving you a tip for if your car ices over in an ice storm, you might want to give this a try.
That moment that you think your car door is ice closed because there's like a 1/4 of an inch of ice over everything and you can't get the car door open, and you're trying and you can't. So you heat up warm water and pour all over it, and then you still can't get it open. Even though you got all the ice off of it, you realize you forgot to unlock the car door. And that's why you can't get it open.
That is key to getting in your
Unlock the car door,
no matter the element.
not the ice.
I always like to say we each put our pants on one leg at a time. All right. Thank you all for joining us this evening. We're gonna have a good time and we're gonna learn a lot. I do a lot of educational things for BioLace and across the nation, doing Zoom calls, Zoom meetings, doing large conferences, things like that, from the Greater New York, Florida Dental Conference, the AAPD annual session, to the Southwest Dental Conference, all sorts of things there. We are hosting, as Joe said, our third annual Tequila and Tongue Tie in Miami. That is coming up quickly and almost a month away. So there's still time to register, and I hope to see y'all all in Miami. It's gonna be fun, but we're gonna learn a lot too at the same time. Full disclosure, I am generously provided for you this evening by BioLace without their help in helping make these educational resources possible. It would be so much more difficult for us to learn from each other and learn the best cutting edge educational resources so that we can best take care of our patients where we are. So for tonight, what we're going to talk about is we're going to identify indications for both children and adolescent frenectomy treatments. We're going to utilize age-appropriate pre-op and post-op assessment tools. And we're going to create a step-by-step technique for both children and adolescents with a frenectomy using an all-tissue laser. First, let's ask ourselves, why do we care about a tongue tie in a child, okay? Last time we talked about why we cared about a tongue tie in infants. So this time we're gonna focus on children and adolescents, okay? Let's think about this kid, okay? The picture we're seeing on the top left up there is the child raising their tongue all by themselves. Basically, it's not happening. We use this fancy little device called a groove director to lift the tongue up, thus exposing this very tight, short, thick tongue tie or a restricted lingual frenum. Once we've released it, now the child is able to lift that tongue up immediately post-operatively, and then within a week, it's healed beautifully like this. So we have to ask ourselves, for this child, is this normal for them to look like this? Do you think this is adversely affecting them? Do they even notice that this is a problem? Or is this just something that they're living with on a daily basis? Perhaps this is something that hasn't crossed their radar of concern, but they've been compensating with for years. Perhaps this is something that you planted a seed of thought and then you opened up Pandora's box. One thing I always want us to look at when we're looking at a lower anterior crowding with spacing between the lower centrals. Do you see the space between the lower centrals? Anytime we see that, crowding with spacing between the lower anterior centrals, look at the tongue. What happens here is this tongue on extension is going between this, causing a very slight diastema. That is a red flag. Once you see it, you can't unsee it, and it's really impressive when you find it. So I want you to take that little nugget and put it in the back of your mind and hold that. I like to say in our practice, we grow frenectomies too. So there's not something that, oh my gosh, this is like an abscessed tooth. We must address it ASAP or problems are going to happen. You're like, oh, this is a big, big deal as far as kind of emergence care, life-threatening situations. Frenectomies generally fall within more of an elective realm of treatment as opposed to urgent or emergent care for the most part of children. And so a lot of times we're bringing things up, pointing them out as points of growth and development concerns and things we're tracking, things we're discussing. And over time, we have children as they become of age or they become from childhood to teenagers, they can vocalize and understand more what's going on with their body. They can communicate more with us what they're feeling. And then we can have a much more pointed conversation about what's going on with their tongue. And that's exactly what we did with this child. Let's listen to her.
I'm 14 years old and I was having under tongue issues that we talked to Dr. Curtis about.
Can you tell me some more about those issues you were having with your tongue?
A few of those consist of a lot of pressure under my tongue when trying to get food out of my teeth, a lot of pressure when trying to touch the roof of my mouth, and although I didn't have speech issues, it was a little harder saying a few words because I feel like I was tongue-tied a few times. Yeah.
What about pressure in your neck? Did you feel like you had some pressure in your neck before? Yeah. And then we did the release about a week ago. And can you tell me how it's been? Can you tell a difference?
Yes, I can tell a difference. I feel like I've been speaking a lot more clearer, and it's been easier to reach through from my mouth and to get food out of my teeth, and there's been less tension on my neck, and it's been great.
How was the right after release? Was it really uncomfortable? Not so bad? Tell me more about how that was.
It was uncomfortable for about 1 or 2 days, but after that and doing my exercises, it really helped, and I started to feel less tension, and that's when I started to see more of the benefits.
Big question, would you do it again?
Yes.
Perfect. Thank you, dear.
I love this story because this is literally the child speaking in her own words. And what we're going to see is a lot of these symptoms that she started to feel and started to report are the things that we're looking for at this age. And so she was a perfect patient because just a year before, 6 months before, she hadn't reported any of these issues, but a magic thing had happened. She finished orthodontics, and look at that beautiful smile. The orthodontist aligned everything perfectly, and now this tight mouth has been unraveled and stacked together perfectly, and now the tongue is running into that mountaintop, and now she's having issues. We released the tongue. Now the tongue can go over the mountaintop again, and now she's got way more flexibility and movement in there. Novel concept to think about as we're dealing with teenagers post-orthodontics and orthodontic relapses. So we want to be thinking about that. What you can't see is off camera here. The mom is literally crying tears of joy because her daughter sounds like a news anchor. She didn't have speech problems, but her speech was definitely not that clear, literally just a week before. And so pretty impressive for her, and definitely a quality of life change that she felt and was felt by her family. So what is a tongue tie? So as we talked about last time, we're really looking at not just the tissue attachment, but its effects on the area and on the body. So its ability to move around or the impairment of that, the functionality of it or the lack of function there. And we really want to be looking more in kind of the speech, the airway, the growth and development, the feeding indications. So we're going to dive into all of that here. One of the big concepts I want us to remember and take home is really that we have to have symptoms plus some functional issues plus anatomical structures to indicate a treatment. Okay, that's your foundational ability to say that this is justifiable. If we don't have those things, then we don't have a firm foundation to stand on for an indication for a procedure. So we want to make sure that we're documenting those, establishing those, and reporting those, okay? So what is a frenectomy here? Looking at a pre-op and a post-op photo here, what we're basically doing is we're delivering the tongue up and the floor of the mouth down. You're pushing that lingual frenectomy posteriorly and releasing those fascial planes to help open up that tightness that comes from within to help elevate that tongue upward from the floor of the mouth, relieving that tension from the floor of the mouth. Once again, I want you to look at these lower incisors. There's a space between them. We have to describe our phrenems, okay? So particularly tonight, we're going to focus in on the lingual phrenem, but we can't just say a phrenem or a frenectomy. We have to describe which one anatomically we're working with. But what is this tissue? This tissue is not just a buccal fold of mucosa. It's actually fascia, which is a connective tissue that holds your body together, okay? This is what chiropractors get all worked up about, okay? A landmark article in 2019, that wasn't that long ago, guys, swung the pendulum in how we were thinking about these things. Nikki Mills out of New Zealand published this article in Clinical Anatomy where she identified this not just as a fold of mucosa, but of tight skirt fascia, meaning the anatomy of the area was not just a soft tissue, it was the connective tissue underneath, not just that outer mucosa layer. So when we're releasing this, we don't just want to clip the edge, we want to release through the tightness, okay? So what's really the problem, right? Let's dive into some symptoms and some signs of what we really need to be thinking about What needs to be in our mind's eye as we're dealing with a patient that when we're looking at the tongue, we're thinking, man, that looks not right. What might be some problems that we're having? Okay. As we talked about last time in part one, I like to think about this as a continental divide. You've got infant issues on one side and then everybody else on the other. Okay. So today we're going to be on the other side. So it must be age specific that we're looking for, okay? We kind of recapped this last time. You can kind of think about it in infant symptoms, baby symptoms, toddler issues, school age issues, teen issues, and then everybody else, all right? We're not going to focus in on everybody else because guess what? I'm a board certified pediatric dentist. I don't deal with everybody else. I'm in your teens and unders, all right? The best part of the population. When we're working with this, we want to make sure that we have a team approach, okay? When we're looking at children that are having speech issues, you want to have a speech therapist on board. The potential of them miraculously having speech improvements just from releasing their tongue is pretty low, okay? That's just like having a knee surgery and miraculously not having any issues after your procedure. You're healed. No, it's a lot of work to get to that healed status, okay? We're working with fascial planes, so sometimes it's really important to involve chiropractors, myofunctional therapists as we're retraining this tongue that may have been compensating for years, okay? Craniosacral therapists can also be exceedingly helpful as we're working through this as well, okay? So we just want to have an open mind to those other healthcare providers that can be key players into helping make the child's recovery and strides for health easier and more predictable. At the end of the day, you own the mouth, okay? The slogan coming to us from the American Academy of Pediatric Dentistry is America's pediatric dentist, the big authority on little teeth. I would challenge this to say the big authority on little mouths. We own the mouth, not just the teeth. All right. We are called to serve from the lips to the roof of the mouth, to the floor of the mouth, and to the tonsillar pillars. And guess what lives within that space? Not just teeth, something bigger, the tongue. All right. And so I would challenge you not to shirk your responsibilities off onto some other specialty care, but to take ownership of that as you, as the specialist of the mouth. It is our job to track the growth and development of that and to make interventions when appropriate. Let's take a look at school age issues. The biggest one that comes to us at this age is going to be speech, okay? Speech normally reaches its formation at around 7. So that means most children by first grade have been identified as having speech problems. So if you're in a public school system, you normally are tested by a speech and language oral pathologist at around that age where they are trying to diagnose you from a diagnostician standpoint of trying to have issues and construct a plan, okay? This may be something that comes to us before then from the pediatrician as the parents are voicing their concerns to that. This may be something where they've been through speech therapy, yet they're still having issues. Sometimes we get these 10-year-olds. I had one today that it was very difficult to understand him, right? Guess what? He didn't have a tongue tie. He actually had developmental delays and was autistic. And so that was the source of his speech delays. It wasn't related to a tongue tie. But a lot of times at these early ages, the parents may be coming to you for an evaluation just to verify that those oral structures are appropriate. So we need to recognize not only pathology, but normalcy, okay? Because I always like to say, you can't put a price on peace of mind. And us pulling out a Jenga puzzle and saying, that piece is not related here, sometimes is just as powerful as saying that, yes, that is one of the pieces of the puzzle that will be an issue. Let's go ahead and make an intervention. So in speech, we want to understand those normal milestones for the ages, but we also want to understand we aren't the authority on speech. We need to get those involved that are, okay? Airway. Man, if there's a hot topic in pediatrics over the last 10 years, this has been it. Our understanding of airway has changed and it's changing so much. And if there's one slogan that I am just loving, it's this from the Breathe Institute. Tongue up, lips closed, healthy breathing through your nose. I live in an exceedingly high environmental allergen area in the in America. All right. We have the edge of a forest and the edge of a great prairie. Okay. So you get all of the grasses from the prairie, all the dust from the prairie that come together with all the piney cedar trees. Okay. We get so much that comes together, and all of us pasty pale people have a lot of these allergy issues. And so it melts together for us here. And so this is something we talk about a lot in my practice is airway assessment, tonsillar issues, tongue position, breathing, that growth and development of the facial structures, that long face development, the circles under the eyes from the exhaustion. All right, we want to make sure that we're diving deep in that, knowing that the tongue may not be the problem, but the tongue could be a contributing factor in a solution. Okay. Sleep. This is another big thing that we're seeing as it relates also with breathing, but sleep. If children don't have good quality sleep at night, they tend to be lower performers in school. They tend to have more reactive issues, sensory issues, ADHD, and struggle with things like that. There's a healthy concern that a lot of ADHD children don't actually have an underlying psychological, neurological issue, but it actually may be related more towards their lack of quality sleep. Okay. One of the most interesting things we talk about is not just the circles under the eyes or the snoring, but it's actually the bedwetting and restless sleeping. Okay. I had a child once that had gone through years of speech therapy. The parents were so frustrated with their bedwetting. And we talked about how this might be a potential issue with sleep, a potential issue with breathing, a potential issue with oral structures, including their maxilla being high and vaulted, narrow palate, crowding, crossbite, and a restricted tongue. The parents' mind was blown and they cried. They wept because they were so frustrated at their child that they could start to understand that this might not actually be their child's fault, but actually symptoms and signs of deeper issues that needed to be resolved. You have the ability to advocate for that child if we're looking for it. They live within your population and they need you, all right? Cleansability. I never thought of cleansability as an issue with the tongue. Catherine Flights, Dr. Catherine Flights, she is a board certified pediatric dentist and a board certified oral pathologist. And she was giving a lecture on pathology. Imagine that, particularly pediatric pathology. And she talked about oral diseases and how ankyloglossia and tongue tie really can increase your risk, not just for caries, which is what you normally think about oral diseases. It can increase your risk for other oral diseases because the tongue, one of its main jobs is actually to be a street sweeper, to clean everything around from your vestibules to the roof of your mouth to the top of your tongue, that shag carpet on the top of your tongue. That needs to all be done. That is the job of the tongue. And if you're not doing that, then my goodness, it's all getting caked in there. I had one child that had a severe tongue restriction, packed food in the maxillary vestibules, and had a horrific fungal infection up there. Took 2 rounds of antifungals to get that to go away. A good way to test this, if I'm saying like, do they put their hands in their mouth? Do they tend to smack and chew and are they putting their hands picking in their mouth a lot while they're eating? You'd be surprised how many parents like, yes, they're such a sloppy eater. It's been a struggle. I tell them to go home and give them a spoonful of peanut butter and watch them, okay? If they're not able to move that bolus of peanut butter around, if they're having to pick at it to get it out of their teeth and out of their mouth, they're definitely having some issues there. So that can be an easy test if we're concerned. Let's think about teens. There's one thing with teens that every teenager, no matter where you are in the world, wants to be. They want to be normal, okay? Every teen is going through so many changes with their bodies, with their emotions, with their mind, with school, with all of these pressures from society that they're feeling. All of that is going on, and there's one thing they want to be is normal, okay? To them, it may be a huge deal not to be able to lick an ice cream cone normally. They may be starting to feel a lot of tension in their necks. Remember that 14-year-old said she could feel pressure through here that was relieved afterwards because that tongue attached through fascia to all of these muscles through your face and your neck. It's crazy. Most muscles are attached to bone, okay, like your bicep, but the tongue is hardly at all attached to bone. Everything is through that. Kissing. Yes, I talk about kissing in my office. Maybe it's not applicable to the 10-year-old. Maybe it shouldn't be applicable to the 16-year-old, all right? That's not for me to say. But what I do talk about are quality of life issues. And definitely, if you can't move your tongue around, you're probably going to feel like you're not normal when it comes to social interactions and things like that. So I do bring that up and discuss that with comfort with my patients and their parents, okay? Speech. Definitely, again, we're dealing with speech in teenager years. Sometimes they may be quiet for a reason. Maybe they just feel like they get tired when they talk, okay? Maybe they feel like they just can't say words like Constantinople. I mean, don't you all want to be able to say that? I'm just kidding. But, like complex sounds and pronunciations and things may be difficult for them. They may feel like that tongue is rubbing across their teeth and it hurts when they're eating. You would be surprised how many of these teenagers that I talk to about that are like, yes, that hurts. And the parents like, well, you've never mentioned it because they just live with it. They know no different until we talk to them about it. You are advocating for them. You're helping them put their world into perspective. Okay. You are sharing a very specific perspective that they have never been shared to them. They are learning, they are sponges, and we can help them understand their body better and help them make better choices. Okay. How do we document all this? Man, this sounds like a lot to have to talk about. I mean, I just was expecting to do a regular recall. I walk in and I'm looking at x-rays, the teeth. Well, now this tongue. Oh my gosh, how do we do all of this? Okay. If we're gonna grow a frenectomy, a questionnaire, all right. If my hygienist or assistant is noticing that there's a tongue issue in there, they're taking that child a screening form for the parent to fill out, okay? If the parent is reporting a concern about that, they're taking that parent a screening form. If they're calling on the phone and that's one of their chief complaints in the appointment, we're sending them the screening form to fill out ahead of time, okay? It must be an age-specific screening tool, okay? You do not want to ask a 13-year-old about breastfeeding, okay? Not applicable, okay? Maybe you can ask the parent did they breastfeed? How did it go? But definitely we want to make sure we're not asking about their current breastfeeding issues and maternal symptoms, okay? So it has to be age specific. Where do you get these said tools, okay? Thank you, Dr. Richard Baxter. He wrote the book on tongue ties. He gave a wonderful lecture last year at AAPD at the pre-conference symposium. He provides these free accesses to you, these free assessment tools on his website. So you can access them there. You can download them. There's both infant, adult, and children ones. They're PDFs, so you can edit them for yourself how you want them to be. Mine, I have taken and edited them. We've put them into our Weave platform. And so the parents can actually be sent that through text, fill it out on their phone, and send it back to us, and we can upload it in the chart. It's beautiful, all right? So there's no reason we can't have these filled out ahead of time if we know this is a concern for the parent coming in, okay? Or if we know this is a concern before the doctor gets in the room, the staff can easily have that sent over to the parent, have them fill it out quickly, and then I can come in already having this answered, okay? Let's dive through this assessment tool. Like we said, one of the biggest things we might be seeing is speech issues, okay? And one of the things we see a lot that you might not think about is frustration with communication. We get a lot of that where the parent's frustrated trying to understand the child or the child is frustrated trying to communicate. For this, it's a really big red flag for me where do they just not have the words or the words just not coming out clearly or are the words literally just not coming out? Because you can have apraxia where you're just not able to get the word out. Like you have the words in your mind, but you aren't verbalizing them. We'd be looking for a child that is trying to verbalize, it's just coming out very sloppy and very difficult. That would be a child that we'd be having more on our tongue tie radar. If they don't have the words, that's most likely a different developmental struggle. So we want to make sure that we're diving deeper into that to help the parent understand that it may not necessarily be an anatomical structure. It may be more of a developmental or neurological assessment that we need to be going through to dive deeper. With feeding, picky eaters, textures, all of that. I love to give an example of my number 3. All right, our third kiddo. He definitely struggled with a lot of things. He is very, very particular, very, very immature, and wants to be little. Okay. He still refuses to eat things all the time. And it is not because we don't offer them, it's not because we don't talk to him about it. We're literally explaining to the child, you can chew it up and spit it out if you'd like, but if you like it, you'll chew it up and swallow. It's that easy. He don't care. Okay. So those kids are out there. All right. The kid can eat an apple, peel it off, chew it up, swallow it, eat the whole thing without a problem. He obviously does not have a oral issue as far as with chewing, with biting, with muscle strength, with tongue movement. He just does not prefer those things. But he's not every child. There is a healthy amount of those children that are picky eaters for other reasons other than just behavioral personalities. Okay. Another thing that we notice a lot too is speech therapy, where they're reporting they're in speech therapy, but the parents is very frustrated because the moment they stop speech therapy, they're regressing backwards, or they've been in speech therapy for so many years and they're just not making those progresses. So those are both really big red flags for a deeper underlying issues there. When we're looking at speech, one of the things we want to think about with speech therapies is not just how long you've been in, but who is your speech therapist? A lot of times, if we're in public school systems receiving speech therapy, that may only be once a week for maybe less than an hour, maybe 30 minutes to 15 minutes, maybe in a group session rather than a one-on-one session. So the quality of that may be something where we need an improved situation there. We might need more one-on-one time or more frequent visits. And that may be something that is out of the realm of a public school system to be able to offer. And we might have to be making sure that we're giving options for private speech therapy and being very real and frank with those parents. We also want to help parents understand the developmental milestones so that they can really help understand for themselves to whether or not this may be an age appropriate thing or something that we might need to visit more with the pediatrician about as far as our growth and development milestones. One of those big things always comes down to autism, developmental delay, sensory issues, Down syndrome, things like that. We can have a lot of underlying health conditions that can be affecting speech. So we want to be open-minded to those as well, okay? Feeding issues, as we mentioned, sensory can be a big player in this. We can have autistic kids that really only eat 3 things and that's it, just those 3 things. It's life-sustaining, but boy, it is not helpful. It's very frustrating for the families. It can increase their caries risk. It can be a lot of issues, but that may not be anything to do with their tongue. But definitely that may be something where we are assessing their tongue to rule that out as a problem, okay? With feeding issues as well, a good speech therapist with us can be very helpful to help them work through those things, or even an occupational therapist as we're working through trying different textures and things like that can be very helpful. One of the big things with that too can be gagging and vomiting. Why are we gagging and vomiting? Like that can be an underlying neurological or GI issue too that may be somewhat related to the tongue or may not be. We want to make sure that we're being open-minded to overall health issues, not just being closed-minded to the potential of the tongue, but the reverse is true too. We don't just want to be open-minded to these overall global systemic issues and forget that the tongue might be a player, right? It's a double situation, okay? Other things you might not think about when it relates to these assessment tools we might want to ask. Bedwetting, as we've mentioned, that can definitely be a telltale sign of sleep issues in older children. That hyperactivity, inattention, ADHD symptoms, that can definitely be an issue once again of sleep and things. Neck, shoulder tension, headaches, migraines, things like that can definitely relate into when we're looking at how that tongue is compensating over time, okay? Right, sleep, as we mentioned, that brain has to have quality sleep for us to get good development. And I am mentioning that to parents when I see the dark circles under their eyes, when I'm worried about the congestion, when I see the large tonsils, when I see that this tongue is not able to properly get up to the roof of the mouth. We're talking about who all we might need to work with so that we can get that child healthy, okay? So that we can get their brain developing better. Mouth breathing is not ideal. Mouth breathing is not normal, all right? Once again, I grew up in a very high allergy area. The majority of my childhood was spent with Kleenexes, runny noses, and just on all congestion. I was a snotty-nosed kid, and it is a wonder that I did not end up with a long-faced jaw structural issues. I must just have strong epigenetics to overpower that because I was a classic mouth breather. There was no way I could breathe through my nose the majority of my childhood. Back then, allergy management wasn't something that you did normally. And so, thank goodness nowadays, when we're looking at that, an allergist might be someone that is very important for us to involve. Okay. I'll say it again. Dr. Zaghi's tongue up, lips closed, healthy breathing through your nose. Thank you, Dr. Zaghi at the Breathe Institute in Los Angeles, for helping us better understand that so that we can communicate that effectively to our patients. Let's look at diagnosis, okay? We want to make sure that we're not just documenting things from a questionnaire, but how do we put that together anatomically and functionally, okay? So we want to make sure that we've got that symptoms questionnaire. We want to make sure we have intraoral pictures. We have to have a good note that's documenting the anatomical presentations. We need a classification system. An easy one that I really like is the Kotlow classification coming from Larry Kotlow out of Albany, New York. He is, I like to call the godfather of laser pediatric dentistry and frenectomies. We want to make sure that we're evaluating both that functional and movement, okay? We want to ask who we want to work with, okay? Or who is this coming from? I get lots of referrals coming to me, and I always want to document them and reach out to them as well to make sure we're best taking care of each other's patients, all right? Once again, our assessments are different. How we're going to assess a baby is going to be different from how we're going to assess a child and an adolescent. Every time we're assessing, we have to talk about what frenum it is. You can't just say you're talking about a frenum. You need to tell me which one it is. If there's any takeaway from today that you're getting, you must take intraoral pictures. You must take pre-op photos. Just like you wouldn't do a filling without having an x-ray, you shouldn't do a soft tissue situation like this without a pre-op photo, okay? Some clinical things we want to look at. Well, is it an anterior attachment? Is it a posterior attachment? When you raise that tongue up, can you actually touch it to the roof of the mouth? Or does it get halfway there? Or does it get 75% there? Is there like an Eiffel Tower or tinting underneath the tongue where the salivary glands are getting pulled up? If you rub your finger under there, is there tension in the neck, tension in the tongue? So we want to be thinking about those sorts of things and documenting them. This is a classic Eiffel Tower look, okay? Interestingly enough, we'll look and see that they've got a lingual bar, all right, from ortho. So maybe that is kind of as exacerbating the situation. We want to take different pictures. So I like this example because the child struggles to elevate their tongue, period. They can't stick their tongue out at all. We can grab their tongue and lift it up, and you can just see how vast all these fascial connective tissues are. So if you just clipped the anterior portion, it is not going to do anything for that posterior realm. So we need to do a full release and release all of that fascial tight connective tissue to once again deliver the floor of the mouth down and the tongue up, okay? Here's what we're looking at from a Kotlow situation. We've got 1, 2, 3, 4, all right? Where 1 is kind of more of a mild situation up to a 4, which is more of a severe, okay? Classification is important, but classification is not everything. You can't make a full diagnosis based upon the classification system alone. The classification helps us understand and picture in our mind what we're working with. Just like a DO carries on tooth number B, I can imagine what that looks like, okay? Just by you telling me that. I'm going to beat this a million times into your minds. symptoms plus function plus anatomical structures helps you have a firm indication, all right? When we're treating these symptoms, all right, or treating these, the old school method, oh yes, we are going to break out scissors or scalpels, all right? You lift that tongue up. You are going to isolate it with hemostats. You're going to slice down each side and you're going to stitch it back up together. Is that wrong? No. But is that necessarily the minimally invasive way of handling this? Not at all. Is that going to be a good result? Yeah, that's still a very classical approach to a surgery. But is that the best way, or is there a better way of doing it? You have to ask yourself, who wants to sign up for that? Maybe there's a reason frenectomies have not been done. I'll be fine not kissing and not licking an ice cream cone if that's what I have to do. Maybe generations have felt that way, but now with a new way of doing this, with an all tissue laser that's minimally invasive, which is versatile, which makes this so much easier. Maybe this is part of what is helping us get better care, okay? How does this laser work? Our laser we're looking at is an erbium YSGG, and it functions at a 2780 nanometer, and it is attracted to water. Guess what your body's made up of? Water, okay? So it loves the soft tissue, okay? What does it do? It heats that water up in the soft tissue and it vaporizes it. Luckily, it's not a mass explosion. It's a very, very tight, very minimally invasive, small, controlled release, okay? The depth of penetration of this is only 5 to 10 cell layers. The scalpel in a slice will slice through 100 to 300 cell layers, but a slice with a water lace is 5 to 10 cell layers. It's very, very minimally invasive. There's less trauma, less necrosis, less bleeding, less post-op inflammation, and all that translates to is less pain and quicker recovery. When we're comparing our erbium YSGG, the water lace, it generates way less heat than other lasers on the market. Particularly the CO2 is known for being hot and fast, okay? But it's not necessarily the best, okay? Our recovery time for most of our procedures tends to be 1 to 2 weeks. We do have some that take longer, but I'd say the vast majority of our patients report full healing in about 1 to 2 weeks, okay? The handpiece on this is super similar to what your normal kind of high-speed handpiece would be. It doesn't have a burr, and you're not touching the tissue, okay? You're gonna hover at about a millimeter away. That helps you be really, really precise. That is the working length. So if you're 2 to 3 millimeters away, nothing happens. So if the child moves, guess what? If the laser is still firing, it's not destructive, okay? That is a great safety net when working on children. I get asked a lot, what tips do you use? There's a tip that slides into that. So if you're a current user, this gibberish will make sense to you, okay? If you're not a current user, let's get you up to speed. So my favorite tip for soft tissue is an MZ56 or an MZ66, as I love to call them sisters, okay? I use that for all of my soft tissue procedures. You can also use an MC3, which is a chisel tip, which is a reusable contact tip as well. Some people really love that tip. How do we go through using this? One of the things I love most about this is how user-friendly it is. You literally like click the soft tissue button on the home screen, click the frenectomy button, I click the rapid cut, and then away I go, okay? Within 3 clicks on a touch screen, you are predictably to where you are. I don't mess with all the settings. I just use the factory preset and I make it work beautifully for me, okay? You can go in there and you can up the watts, you can up the joules, you can up this, you can change the water, the air, you can change the frequencies, you can do a lot of things with this laser. I just love to keep it simple, okay? That is just my style, all right? The first thing we need to do is to take a picture, all right? Second thing, get our laser safety glasses on. Who wears them? Everybody in the room. The kids wear them, you wear them, staff wears them, a parent that's in the room wears them, all right? How do we control that crazy tongue? Old school was with sutures and holding it up. Now we're going to use a fancy Mickey Mouse spoon, all right? AKA a groove director. These come in many forms and fashions. You can get them as easily off of Amazon. These metal ones just like this that are autoclavable. My new favorite one is a plastic one that we've gotten that has a little grippy handle, and it's an autoclavable plastic. It's great. In a netterish sketch here for you, think back to anatomy. We're gonna lift up the tongue, we make a release, and then you're going to see the floor of the mouth drop down and the tongue elevate. Okay. Do we numb? Yes, I numb for my children. Okay. I love a compounded topical. Okay. Here's the recipe. You can take this to any compounding pharmacy and ask them to make it. They normally make you a big tub of it. Okay. Or a really big syringe of it. And a little bit goes a long way. If you're able to get the best topical ever, okay, that comes out of California, it truly is the best topical ever. It's even better than this compounded topical. We can't get this in Texas due to pharmaceutical reforms. Gotta love bureaucracy, okay? I do an injection, a slight infiltration into the area. When I say slight, I mean little, okay? Like a tenth of a carpule, just enough to blanch the tissues. Do not put a large bolus in there or you'll distort your surgical field. You've ruined the anatomy and you've made the surgery so much more difficult on yourself. Self-inflicted pain, okay? For you, all right? There's no wait time for this. The moment you do the injection, you can pick up the tissue and start cutting. Once it's blanched, that lidocaine is there and away you go. You're not waiting for pulpal anesthesia like you would in a tooth. All right, let's walk through this. Woo, man. All right, let's dive into these. Where do you even start with this guy? Okay. As we're lifting this up, it's like, oh man, what is this? These frenums all look so crazy. All right. Remember our anatomy. We are going to deliver the floor of the mouth down and the tongue up. So we have to make the incision superior to the salivary glands, okay? Inferior to the base of the tongue. I advocate for a horizontal back and forth movement. That way you're not as much going into a vertical direction where you might hit the salivary glands or the base of the tongue, okay? So once again, we're going to start superior to the salivary glands, inferior to the base of the tongue. All right, we make a sweeping motion, moving backwards, okay? Seeing that tongue go up and the floor of mouth go down. This is not a race. I cannot say that enough, okay? You do not have to do this in 10 seconds to be a winner. The patient doesn't care if it took you 5 minutes or if it took you 30 seconds, okay? All in all, they just want you to get the procedure done well, okay? I want you to be thinking about that, okay? We put a lot of pressures on ourselves that are unnecessary, okay? When you finish, you're going to see the fascia underneath. You're going to see all of that connective tissue becoming so much more relaxed, and it normally is a diamond-shaped surgical site. Sometimes there's absolutely no bleeding. Sometimes there's a little bit. Particularly sometimes babies get really upset, and so we have to help them calm down, and then bleeding goes down, okay? When do we know? What are we looking for to stop? When that tongue goes up and that floor of the mouth goes down. I love to take my finger and rub it over the floor of the mouth to feel that gentle release, okay? If I'm still feeling pressure down there, I'm making sure I've gotten all of those deep fascial attachments. Remember, we're releasing fascia here, okay? We're helping send that floor of the mouth down and the tongue up, okay? Once again, keep your landmarks in mind. I hear a lot of people that are very nervous about doing these procedures, and most of that is just not understanding and feeling comfortable with the anatomy. If you feel comfortable with the anatomy, this is a very simple, predictable procedure, okay? Once again, we're gonna take a pre-op photo and a post-surgical photo. I want you to take a picture immediately afterwards so that you can show the parent what it is, what it looks like, so that way they're not going home or to the parking lot and being like, oh my gosh, that looks horrible. You'd be surprised. We learn the hard way. Learn from me, okay? Show them the picture and upload it into the chart. That way, when they come back at 1 week, you can show the parent what you started with, where you took them, and where you are right now. If you're working with a myofunctional therapist, chiropractor, speech therapist, you can show them all of your documentation, and it really helps to build trust, to build that rapport, and to make sure you're taking the best care of your patients. One of the biggest pro tips I like to call it to give you is to use that finger to feel underneath that tongue when it's elevated, when it's moving around, so that you can make sure that it feels nice and smooth and released. To suture or not to suture? This is a growing question. For years, the only way to do this procedure was with suturing. Then, with developmental minimally invasive techniques, we've really stopped doing as much suturing, and particularly under a certain age, we're not seeing sutures as much. But what we're finding in older children, if we can put a few sutures in there, you don't really have to do any of the post-op exercises as much, but your exercises are more in functionality, not in helping wound healing, okay? So by a primary closure of, let's say, a teenager, which is what this case was, we're able to get a much more predictable, easy post-op release, okay? So this is his pre-op photo with him elevating and at rest. You'll see how thick and short and tight that is all the way to the tip of the tongue. We've sent clearly the salivary glands nicely downward. We've sent the tongue upwards, and we put a couple of interrupted sutures in there with chromic gut. And then we bring the patient back in 2 weeks. I like to see my secondary intention, so no sutures at 1 week, sutured patients in 2 weeks. The sutures should have resolved and dissolved, and now we should see nice healing occurring. Excellent elevation. We've taken the patient from here to touching behind his front teeth. So this is what we want to see. These are the pictures, all right? This is a quick, simple procedure. We started here. We went from this to this in less than a minute. Look at this space between the teeth. A space between the lower anterior teeth. I told you, once you see it, you can't unsee it. This is one of the beasts, okay? A lot of times you think it's gonna be this procedure. Ooh, this is so thin, this is so simple. This is not so thin at all. It's like, how many frenums do we see, okay? Once again, it's very important to know your anatomy, and I advocate for that horizontal release. This is immediately post-operatively, and this is 2 weeks at this point, okay? This is another one where we have to make sure we keep that anatomy in mind, okay? The release is in this area right here, okay? We'll come back and revisit this one. This is a child we did not do suturing on. You can see how beautiful that area has closed together and function. And so just by doing elevation techniques with the tongue, we can really help get better primary versus secondary wound healing. And you can see how beautiful this result worked out for this patient in literally 1 week, okay? So minimally invasive. This laser is so kind to the tissue. Take those post-op pictures, okay? Here's another one where we can see how short this is. Look at the space, again, between these incisors. Crazy, right? All right, this doesn't look like a huge release, but it was attached all the way here. We traced it back and made sure we sent the salivary glands down and the tongue upward. Look at this beautiful extension immediately post-operatively, and this is 1 week. We've gotten beautiful healing there, okay? Let's talk a little bit about post-op care to finish up here. So we want to make sure that we're sending home post-op care instructions, and one of the biggest things we want them to help understand is that you do need to be managing pain, okay? And so I do not recommend oral gels and things like that. I do recommend Tylenol and ibuprofen if applicable for the patient, and also arnica or homeopathic remedies as well can be nice. So Tylenol, ibuprofen, and arnica. Arnica can come in a gel, which is both intraoral or extraoral. They have the extraoral one in the icy hot section at most grocery stores, okay? The oral forms can come in your supplement area or also in like an infant teething area as well. Stretches. So for the tongue, the big thing is we want to lift that tongue upward, okay? These are my infant post-op instructions, but what I want them to do is I want them to be lifting that tongue up to touch the roof of the mouth. We want it to be doing it 4 times a day for at least 2 weeks, okay? For the lip, we want to be lifting that up to the nose. For the tongue, for kids, I like to say, for extension, you get a small little disposable cup, a medicine cup, a shot glass, whatever you have handy. Put some peanut butter in there. Put some chocolate syrup. Put some maple syrup and lick it out, okay? That is a great extension exercise, doing those 4 times a day. For elevation, you can do tongue clicks. So click that tongue up, hold it up, and then let it release. Or you can also take a little M&M and hold it to the roof of your mouth and see how long you can hold it there, and do 10 M&Ms and be done. All right. an awesome thing to do, particularly as you're building up your patients and you're trying to feel more comfortable with it too, is calling them or texting them later that day or the next day, be it you or a staff person, just to check in on them for your peace of mind and for also the parents' peace of mind. It's a great rapport builder, okay? 1 week follow-ups. Once again, if I'm not suturing, I'll see you back in 1 week. If I am suturing, I'll see you back in 2 weeks, okay? What we're looking for is improvement in symptoms, okay? And we're also looking at a healthy attachment. We want to make sure that it's healing elastic and you're not getting a fibrotic or an adhesion where we need to go back in and re-release that. It is much easier to go back in at 7 to 14 days as opposed to kind of 4 to 6 weeks, okay? Once again, we want to take pictures. Pictures speak 1,000 words. Pictures can show you what you're doing and how you are making an improvement for those patients too. A post-op questionnaire, I'm going to be honest, it took me a while to really want to do a post-op questionnaire because it's like a grade. You're grading yourself almost like, oh, did we do good? Did we help this child? I love these, okay? Because I'm having the parent tell us, do you feel like there's been an improvement or not? How much improvement? What are we improving? Who did we go see? Did we see that chiropractor or that myofunctional therapist like we talked about, okay? Or if you're working with them, have you gone back and seen them? What symptoms are still persisting, okay? I want us to think about this child, this 14-year-old. She may be living in your community within your practice right now. Once again, we had seen her for years in our practice, and every 6 months we talked about this tongue. There were no symptoms. There were no issues, although there were anatomical things that were definitely on our radar until the day that the child herself learned more about what her body was telling her.
I'm 14 years old.
Keep her in mind, okay? Let's talk about just a couple of normal post-op complaints or post-op things to look for. I always like to mention this. There is going to be a yellow to tan film. It's going to be a scab that forms over the surgical site at around day 2 to 3. You need to verbally tell the parents this or they're going to freak out when it changes to that at that 2 to 3 day marker. They're going to think it's an infection, okay? You're definitely going to get a phone call. I have it written in my post-op instructions, but I verbally tell every parent that. And I tell them to keep doing their exercises until that yellow scab or that white scab goes away, okay? And that is a good signification of a scab forming and healing processes, okay? We used to sugarcoat these exercises, aka stretches, a lot and be like, oh, it's gonna be simple. They are simple. They're hard. Some simple things can be quite hard. Threading a needle is simple, yet very hard to do, okay? So I'm very forward with the parents and I tell them, I've got the easy job here. Your job is the hard part, doing these post-op exercises. I don't call them stretches. Stretching sounds easy, okay? Exercising is something you have to force yourself to do, okay? When I think about all tissue lasers, I think about Maya Angelou. Maya Angelou challenges us to do the best you can until you can do better. When you know better, do better. I hope that you could have seen during our time together for both infants and children and adolescents that there may be things that we've never thought about before, that have never occurred to you, nuggets of things that you can take with you into your private practice back where you are to help serve your patients. There might be better ways that you can see of doing it. I definitely see this in my practice every day. This what gets me excited, my staff excited, my community excited, that we can do things better. We're always looking for a better way to do it, and this laser technology is a better way to do this procedure. You'll also notice at the bottom of all of my slides, I put learn, do, serve, because I believe we never stop learning so that we can do good and better serve our patients and our communities. Please reach out to us. There's so many resources available for you on the BioLace website. I've done so many webinars. I've recorded so many things on there. Out there at your fingertips, guys. I'll put one last plug in for Tequila and Tongue Ties. If you've enjoyed this webinar, you are going to love Tequila and Tongue Ties. It's going to be this in person except so much more fun. I'll be there. I'm hosting it. It's going to be great. I'm speaking, and I've got a lot of great friends that are coming with us to talk about it too. Let's learn together at Tequila and Tongue Ties. If you want to reach out to me, here's my email. I'm also very active on social media, both Facebook and Instagram. I run my own accounts, so if you direct message me, it's me you get. All right. It's not some answering service. I'm there. Those are my cases. Those are my patients. That's me. All right. Thank you so much for your time this evening. I appreciate each one of you, and I wish you the very best of luck as you take the best care of your patients. Thank you.
All right. Thank you, Dr. Curtis. Fantastic content here. And thank you to our audience for being with us this evening or wherever you may come from. And let's just touch on just a few questions here, Dr. Curtis. We had a few questions come through. And then once we pick out a few questions, I'll wrap our session tonight with just some instructions on CE. I'll give you a little bit more information about tequila and tongue ties. And we also have a frenectomy protocol guide that Dr. Curtis helped us put together at BioLay's Education a couple of years ago. And I will tell you where to find that as well. So let's start here. Dr. Curtis, the first question is really related to comparing a Waterlase, which is an erbium chromium YSGG laser, to an EPIC when doing a diode. EPIC laser is a diode laser when doing a frenectomy procedure. So is there any technique modifications required or things you have to watch for when using a diode laser in a frenectomy instead of a Waterlase?
Yeah, so definitely two distinctively different lasers, okay? When we're looking at a diode versus an erbium YSGG with the Waterlase, the diode's going to be very, very hot, okay? Where the erbium is going to be very, very cool, okay? So that's one of the biggest differences there. The Waterlase, you're not going to touch the tissue, but you are in a diode. You're going to get a very distinctive charred look to the tissue from the heat of the diode, and you're not going to get that at all with an erbium, okay, with the Waterlase. So those would be kind of the two main differences there. Most referrals prefer not to have that heat and that chard from the diode, and there definitely is kind of a concern in a lot of communities about that heat there, and that not necessarily being the most idealistic approach.
Great, thank you. Let's see, after what age is it too late to expect a lingual frenectomy to correct an associated speech impediment?
That's a great question. I love to think about this as far as the development of your mandible. You have to think about the mandibular development. The mandible tends to grow very great forward, so anterior to posterior, but it does not grow very much in a lateral direction. Once the teeth start coming in, that's the box you got to work with, okay? Once the anterior incisors and the molars come in, we know that tends to be normally locked in pretty well. The maxilla is easily expandable, the mandible is not. And so from quite an early age of mixed dentition, you can really start seeing how that tongue is going to shape up in there, and how if we mold and change the structures around it, how we might be able to make an improvement, how we might make that worse, or how it might not affect it at all. And so truly at that mixed dentition, you'll be able to see a lot more about how that tongue may not have any growth potential left. But there is so much growth potential, so much from infancy into early childhood. That mouth is going to grow and it is going to change. So I love where your thought process is coming from. That's an excellent question.
And to our audience, there were a few more in here, and I'm sorry we're not going to be able to get to all of them just in the essence of time. But one more, Dr. Curtis. I know this may be kind of a loaded question because I know you pull in a lot of information around this in your courses. But do you have any tips on how to manage behavior in older children? When you're performing this procedure, or just in general, just managing behavior in your patients?
Yeah. One of the big things we want to be thinking about when we're doing like case selection is we cannot throw out behavior management. That is pediatric dentistry to its core. It's not just what treatment are we going to recommend, but how does that treatment affect the child's cooperation or vice versa. And so definitely there are some children that they are not going to be cooperative for this. And if we are going to be recommending this treatment, then they do need to be sedated, be it orally sedated or be it IV sedated. I do IV sedations with frenectomy releases, and those are mostly related more towards suturing afterwards too, okay? And so if the child is going to struggle throughout the procedure, we have to ask ourselves, for one, how well do we think we can get this procedure done? And for two, are there other ways that we might need to be considering more advanced behavior management techniques? And so definitely we want to be considering that. I use nitrous oxide, so laughing gas is a huge help. We've got TVs on the screen. It literally is a pretty simple, quick procedure. And so that can really help us out. If the child may only be able to cooperate for just a few minutes, you may be able to get them to do that.
Perfect. Thank you for addressing those questions, Dr. Curtis. And to our audience with more questions, or if we did not get to your question, you can reach BioLays Education at education@biolays.com, and we'll be sure to try to get your questions answered appropriately through Dr. Curtis. As we wrap up, I know we had a question in chat about how do I get my CE credits, and well, here we go. Let's wrap things up. And again, thank you, Dr. Curtis, for the great content tonight. Let's see here. So one more little plug here. So you can go to tequilaandtongueties.com. I know we've said a lot about this conference, but I wanted to touch on some of the lectures that are on the agenda for the 1.5 to 2 day conference. So Dr. Curtis will be speaking about Waterlays to kick off the conference, but some of our friends here will speak on outcomes and a step-by-step review of the frenectomy protocol. As I mentioned, we'll have a social media workshop. We'll have a myofunctional lecture on that Saturday of the conference for 2 hours. So lots of great lectures will be at this conference. Let's see here. So if you go to biolays.com to find that frenectomy protocol guide, click on procedures and dentists, and then you'll see frenectomies listed. And that's where you'll find this guide. So I would encourage you, if you want more information about how to perform this procedure with Waterlays technology, that's where you want to go to find that information. More information about education opportunities within BioLays can be found at the Education tab on our website, including the Waterlays Academy, where our courses are listed. For example, our pediatric course that Dr. Curtis teaches for us each year. And then lastly, before I get to the CE credits, our next webinar is on March 21st, focused on myofunctional therapy. So join us for that. And then we're going to wrap up our webinars for the first quarter of the year on March 28th, focused on billing and coding tips. Let's see here. So you must be officially registered to get your CE, and attendance will be recorded via Zoom. Now you are going to receive a survey via email. You have to complete that survey, and then once you complete it, you will get your CE certificate. So that survey is the lever that gets you that CE. It may go to spam, so if you don't see it in your inbox, please check that spam folder as well. So Dr. Curtis's webinar this evening was recorded, and we will upload it on biolays.com/webinars probably in the next day or two. So check that out. And again, education@biolays.com is our website. If you have any questions or feedback for us in the education department at BioLays, please send us a message to that email. Okay, Dr. Curtis, as always, it was a pleasure to work with you this evening. Fantastic information. And to our audience, thank you for being engaged with us. Take care, and we will see you next time. Thank you so much.
Bye, guys.
Bye-bye.